Okay, so my topic is something related to renal domain. But before that, I believe that you all know me as a faculty. So I don't want you to face this type of situation in your upcoming exam. And for that reason, we kept this preparatory mock test 1 month before, because last time we have kept it around 15 days before. So people thought that this much of information you are disseminating just 2 weeks before is just like showing the heaven, and you are throwing us to the hell. And we can see that heaven is not that far away, but you have not given us the chance to compete also. So that's the reason, the first picture, that I want to have the feeling that yes, there are 30 days more, and you can quickly go through the videos, recorded video, because last time also we have not shared the recorded video. That was also one of the thing which we have added this time. Despite all the logistic issues, we have ensured that yes, you should be going through multiple times the videos. Now the exam day, it should not be like Mr. Bean. You should be very thorough and no, not checking that yes, this paper is right or wrong. And I don't want that people should feel, at least after the end of 6 days of extensive discussion, this type of thing, I don't even know what I don't know. Okay, so this is something what I always thought about, and that's why I start with that. Believe it or not, from nephro domain, can you imagine? CRRT was asked in the broad specialty DNB anesthesia theory question last time. So now you can expect from the nephrocritical care side in the DRNB exam, what would be the level of question? So if CRRT could be asked in the DNB anesthesia, so you can be asked about anything. So that is a bottom line. And with this background, I would be starting the first question. The last 5 years we have collected the questions, and I would be little bit now further would be faster to complete all my 264 slides. In next, maybe I may reach 1 AM. Please pardon me. I have told you also beforehand, before starting this preparatory course, to have liquid, not hard drinks, but yes, definitely coffee, tea, or whatever, because 264 slides are there for me. Okay. So the question number one, early diagnosis and biomarkers in AKI. I want, if you have anything to share with me, please post in the chat box, because I don't expect that any other faculty would be with me, because they have already given their best effort, and I want them to take rest, and I will not be able to see the chat box. So you all can unmute yourself and interrupt me if you have some major doubt or you want to clarify something. Now, every question would be having something or other, the template. What would be you should be writing. Now, early diagnosis and biomarkers in AKI. So, if this question is coming, so I am expected to write under certain headings. Now, these are the headings. Okay. Definition, importance, limitations of creatinine and urine output, concept of biomarkers, the types. Again, in the types, biomarker, it could be functional, damage, or stress biomarker. Then some of the key biomarkers, you can give the example. Clinical application of this biomarker, what is the evidence, what are the limitation of biomarkers, the future directions, and in conclusion, you can give a small 2-line paragraph. Now, coming to the definition and clinical importance, we all know acute kidney injury is like abrupt decline in the kidney function, and we normally get to know if your creatinine level is increasing and there is a decrease in the urine output. Definitely, if your patient is having AKI, it would be increasing the morbidity, mortality, and hospital cost as well as the healthcare expenditure. Early recognition allows prevention and intervention. We are not here to treat, rather the prevention is something which we want as an intensivist. Early diagnosis is critical. It improves the outcomes, guides our therapy, and prevents the progression. Traditional markers like creatinine and urine output are late and insensitive, so that is something which we need to address. Now, if we want to know about limitation of the conventional biomarkers, serum creatinine is widely used. They normally take some time to rise almost like 1 to 2 day. And there are certain confounding factors like it influenced by the muscle mass, hydration, drugs. Then the second biomarker what we can take, that is urine output, is very non-specific, influenced by volume status of the patient, diuretics, and so many other variables. So definitely at this point of time, we need to have some novel biomarkers for earlier detection and re-stratification. Okay. Now, if we want to know what is actually biomarker, so definitely I think some or other class have been taken about biomarker, but if yes, we are getting a biomarker related question in the nephro part. So biomarker is a measurable indicator of biological or pathological process. Ideal biomarker should have certain characteristic. It should be early, sensitive, specific, reproducible. It can predict severity and outcome of our clinical disease or course. There are certain categories in the biomarker related to nephrocritical care or kidney. One is functional. Functional means it can detect the GFR, decrease in the GFR. Damage, something which can detect the tubular injury. Stress, that can predict susceptibility or risk. Now, this biomarker should be able to detect kidney injury before the creatinine rise. Otherwise, there is no point of going for some advanced biomarker. And it should be reflecting tubular stress, inflammation, and cell cycle arrest, because these are the things that first happen before we are getting the increase in the creatinine. Now, it should be also able to differentiate functional versus structural AKI. So these are something which we need to know, and if we want to keep it like as a pictorial view, so if you see here, there is AKI where the red box here, there is already damage, so biomarker is positive, and also there is loss of function. Now the two yellow box where the damage is not there, but the function has started declining. So it also would be manifesting as AKI. And also there would be another form of the subclinical AKI where your damage is positive or present in the form of biomarkers positive, but there is no loss of function. So here there is one window which we can just start treating or doing some maneuver where this yellow will not go into the right side top box where your damage has already been there, like in the form of function, or the red one where your biomarker is also positive and there is also no function. Now, the green part on the left top where there is no damage and no loss of function, so that is something which we want. If our patient is in the red box or in the yellow box, we want to take our patient to the green box, which would be a sign of recovery and restoration of the function. Now, if we go to the right, it would be loss of function from top to bottom. On the right side, damage. But if we are going in the form of left side, from the top to bottom to top, it would be recovery, and from the right to left, it would be restoration of function. Now, this is if you want to make it in one pictorial form in the examination, so it is very easy to draw also. I have tried to share with you something which is not again artistic. In the exam, theory exam, you are not there to create artistic view of glomerulus, tubular, tubule, or PCT, DCT, and capillaries or collecting duct. Rather, it should be just like making it some scribbles. You can see here glomerular filtration and proximal tubule function we can get through serum creatinine and kinetic GFR. Kinetic GFR means that is eGFR. Now serum cystatin C, serum NGAL. So this is something related to the filtration and proximal tubule function. Now if there would be something injury happening, so there would be urine albumin excretion that we normally get it through the albuminuria, and also acanthocytes in the urine sediment. Now, if we just go a little bit to the distal, so there is proximal tubule injury. Now, in the proximal tubule injury, you will be getting through the some of the centers habit, that is nephrocheck, and this is urine IGF BP7 that we will be discussing. Now, there would be again, if we go a little bit to the deeper, it would be distal tubule injury, and the biomarkers normally here are urine NGAL, urine TIM2. TIMP2. That is again nephrocheck. So this is something, if in the examination, if you get a question related to biomarkers in kidney, so you can easily write one small box and a picture like this. Now, some of the things also, just for your understanding, if you remember this thing, that is very good. Like, you can keep or create like functional marker, stress marker, and damage marker. And you can see here the functional marker is green, stress marker is blue, and a damage marker is red. I'm not going into detail, but this is another form of like where you can like create different biomarkers as per the different localization. Now, the functional biomarkers. What are the functional biomarkers? I have already told the cystatin C earlier rise than the creatinine, less muscle dependent. Kinetic GFR, which is a dynamic monitoring, it can increase or decrease depending upon the fluid status, and again maybe the augmented renal clearance, maybe depending upon the functional ability of the kidney or the glomerulus to the different like changes in the clinical status. Now coming to the damage biomarker, NGAL, which is neutrophil gelatinase associated lipocalin, early rise within 2 to 6 hours after injury. Now the next one is the KIM1, kidney injury molecule 1, proximal tubular injury marker, and IL-18, inflammation and ischemic tubular damage. In the examination, nobody expects you to write in detail about these biomarkers. Just remember the names and the full form. If you can just write, and also where it actually generated or like produced from. Then the fourth one is LFABP, which is liver fatty acid binding protein, that actually shows how much is the oxidative stress and ischemia. Now the stress biomarker, the third one is TIMP2 into IGFBP7, which is popularly named as nephrocheck, and that is actually showing us the cell cycle arrest, which predicts the AKI risk within first 12 hours. And this is mainly used for re-stratification in the ICU and post cardiac surgery. NGAL, that is neutrophil gelatinase associated lipocalin, that rises within 2 to 4 hours of injury, useful in the cardiac surgery, sepsis, contrast nephropathy. And also NGAL is predictive of the dialysis need and outcome. Now, some of the usual important biomarkers I have tried to like summarize in 2 to 3 lines, so that you can at least write if a question comes as biomarkers in the kidney or like kidney failure or AKI. This is already we have discussed nephrocheck, FDA approved test, predict risk of AKI within first 12 hours, valuable in the critically ill patient. Now other biomarkers already I have shown you. You just need to know that these are like proximal tubular injury, inflammatory marker, filtration marker, like the cystatin C, and that is less influenced by muscle mass. Maybe in the examination they can ask a short question on like maybe cystatin C also. So you need to know maybe little bit about all these things. What are the clinical application and evidence of the biomarkers? They can predict the risk, stratify the risk, and also triage in critical ill or post surgery. Early initiation of nephroprotective strategies, optimize the fluids, avoid the nephrotoxin, so that we can immediately start it before the proper AKI settles in. Now, this can also help to differentiate AKI phenotypes, whether it is functional, whether it is structural. So it is not that all the the people would be wearing the same size of shirt or shoe. So it's not like any AKI you would be treating in the same line. So we need to the phenotype. Avoid nephrotoxins, optimize the hemodynamics, and also we can have some preventive bundles. And as per the KDICO, it is named as KDICO care bundles. And so in case the patient needs dialysis, so we can in the larger trials, some trials have also been conducted based on or using some of the biomarkers. So these are something which you can write about the clinical application and evidence of the biomarkers in the kidney. Now, this again one picture I have tried to create. You can see there is always a lagging in creatinine, but NGAL and TIMP2 and into IGF-BP7, which is nephrocheck, it can immediately like allow your kidneys to like be alerted if you can do it at the right time. Now some of the limitations already cost and availability in our resource limited settings, maybe we cannot get these biomarkers. Variability across the population, we cannot like extrapolate it to different patient categories. Maybe if it is applicable to post-operative state, may not be applicable to the chronic disease conditions. Most are additive. We cannot have a single biomarker to know that whether this patient is having AKI or not. Rather, we normally recommend it as a battery of tests. So that means it is not a standalone thing, rather additive. So must be interpreted with the clinical context. We have to have a very much proper cutoff. Otherwise, you cannot be like very sure whether zero point 0.4 is actually the cutoff. If it is 0.41, you will be saying that yes, no, this patient is into AKI. Not yet universal in the KDIGO guidelines. Also, the guidelines have only suggested, but it is not that very much confirmed in the guidelines. Strongest evidence of the biomarkers in AKI is in the perioperative state, sepsis, and ICU. So these are the situations where actually the biomarkers have been studied in detail. Now, what are the future directions? Maybe integration of this multi-biomarker panel plus AI. AI every time any question, if somebody is asking you what to do in the future, you can always add AI or OX along with that. Move towards personalized AKI risk prediction. And in summary, biomarkers are adjuncts, not the replacement of our clinical decision. Concept of subclinical AKI, which I have shown you, that is the thing that we can get if we use biomarkers judiciously, timely. Multi-marker panels and AI is promising, and the whole idea is early detection enables timely intervention. And maybe these biomarkers overcome the limitation of our age-old creatinine and urine output, allow earlier intervention, but yes, challenges remain still in widespread adoption. Now, the second question, at this point of time, any questions? 5 seconds, or else I will go to the question number 2. Now, question number 2, again, KDIGO criteria for AKI. I hope everybody has known about what is KDIGO and some of the classification about KDIGO criteria. So straightforward, we go to the headings if we are getting a question on this. So these are some of the points. Again, I am not going into detail. Evolution, how come KDIGO came? Before the first one is rifle criteria, then Akin criteria, then KDIGO criteria. Definition, staging, what are the strength and clinical utility of KDIGO? What are the criticism and limitation of KDIGO? How it has been compared with rifle and Akin, and what is the role in the epidemiology and research, and some of the special population like pediatric pregnancy, and what are the future direction. So if you remember certain points in the examination also, you can actually write 2 lines about each one. So my suggestion for all the theory aspirants, that always don't be very much stressed when you are getting a question which we don't know. Rather, you try to divide into certain domains in that question. Maybe a 10-mark question, a 1 line or 2 line question, straightforward. It doesn't have any sections or subsection, but whenever you are writing, just don't straightforward start with this is something like no a and then like an introduction. No, you try to divide or make it into at least 5 to 6 structured domains, and then start writing 3 lines, 4 lines, 5 lines about that each domain. So in that way, what will happen, when you start writing, you will get some idea how to fill up these all these like structured domains. And at the end, when you reach at the last domain, you can see a very impressive template of the answer is already prepared by you. Okay, so don't be fearful and rather face your theory paper very confidently. Now, with this background, if we want to go into the evaluation of KDIGO, rifle criteria came in 2004, Akin 2007, and KDIGO 2012, which was updated in 2023. Now, the aim is to standardize the different the usage and also classification, and also it can be compared with the clinical situation of the disease across the world. Now, rifle, we all know 2004, risk, injury, failure, loss, end-stage renal disease. That is the first consensus definition. Akin came in 2007. that was refined with smaller creatinine increments, and there was a 48-hour time frame. Now KDICO unified both rifle and Akin, and now it is the global standard. Now the global standard also in research and also in clinical practice. It is not only in the practice, also the research. Now coming to the definition. As for the KDICO, I am not going into exact word numbers that you remember or you can go through when we will be finishing our crash course. AKI definition is very important. If they will be asking, you have to write in this format. I have also given you KDICO as for the serum creatinine criteria and urine output criteria. You know AKI stage 1, 2, 3, and within 48 hours, then 6 consecutive hours, 12 hours, 24 hours, urine output criteria and creatinine criteria 1.5 to 2, more than equal to 2 to 3, and more than 3-fold. And the 3, if patient is started on RRT, irrespective of the stage at the time of initiation, it comes to the AKI stage 3. Now, just for the sake of understanding, in any case, if the examiner also asks about, can you like explain about the different classification strategy for AKI? So in that case, you have to also write about rifle criteria and also Akin criteria. Not going into detail, you know, risk injury, failure, loss, end stage renal disease, here stage 1, stage 2, stage 3. So go for it, remember it, put it on your the table where you read, so that all the classification every day, maybe 2 days, you can just have a glance of look. Yes, this is something, because it would be all visualized. So in the examination also, you can just remember that on your table, on the wall, this has been actually pasted, and you can just try to simulate it on the theory paper. Now, strength of the KDICO, harmonize the definition, global adoption, sensitive. This capture mild AKI also. It includes both functional, that is serum creatinine, and urine output criteria. It has a stage-based approach which has prognostic relevance, and it predicts mortality and RRT needs as well. The clinical utility, again, standardized diagnosis, so early recognition, it guides in our management and also escalating the treatment. Like from stage 2 to if the patient goes into stage 3, definitely we need to consider RRT. Widely used in ICU, nephrology, surgery, epidemiology, and there is also a risk stratification in ICU and sepsis. So definitely we need to be very cautious when we are using the guideline in our patients, and this also guides fluid, nephrotoxin avoidance and RRT. Now, there is a common language of KDICO across clinicians and also various trials we conduct. So definitely this is also one of the biggest utility. Now, some of the criticism and limitation of KDICO, creatinine, what we use or there is actually in our KDICO, this is delayed and influenced by muscle mass, volume, and some of the drugs. It doesn't still have the decent biomarkers. Urine output, again, the limitation we know, it depends upon the hydration and diuretic. It cannot distinguish between the different phenotypes of AKI, whether it is functional versus structural. Baseline creatinine often unknown. No integration with the biomarker, the recent biomarker that I have already told. Comparison with rifle and Akin, definitely it integrates best of both. Though rifle is the first conceptual framework that includes severity and outcome, while Akin emphasized early changes, KDICO has a broader time window, that is 7 days, and it retains sensitivity. Now, studies have shown that KDICO outperforms rifle and Akin in predicting outcomes. More sensitive for mild AKI, which I have already told, improves reproducibility, and still it has some complexity, which is its limitation. Now, it has a very important role in the epidemiology and research, as global uniformity is there, but reliable incident data is only 10 to 20% in the hospitalized and 30 to 50% in the ICU. They have used as endpoint in clinical trials, stratifies risk for the CKD and also mortality. And we need to also know that KDICO has certain special population applications, but the KDICO pediatric modification exists, but not in very robust idea. Cirrhosis, ICU sepsis, and pregnancy, creatinine is unreliable. So we all know in pregnancy, creatinine is actually fallaciously low. So biomarkers need to be integrated so that only we should not be depending upon the creatinine. Cardiac surgery and transplant, yes, it is validated but evolving. So future and take home, integrate again biomarkers, imaging, AI. Dynamic models should have real time the electronic health record alerts and AI prediction. And also the KDCO is currently this gold standard, but evolving and useful for bedside research, global comparison. Towards this would be helpful maybe in the future KDCO the revision and structural AK definition. It is critical required in the ICU practice. Now coming to the stage or the question number 3, principles of RRT. Any question at this point of time? Are we all with me or not? Or you have started living? I want again thumbs up from all of you. Yeah, at least 5 to 7 so that we can go ahead. Okay, perfect. Thank you. So these are something I would be very honest with you. Nephrocritical care, if you know something, the examiner will also be not very keen or like knowing the details because it is something a very I would say defined specialty in the critical care. So you need to know something, you will get definitely 7 to 8 marks out of the 10-mark question. It is easy to score, but yes, for that you need to remember or know something about nephrocritical care. Now, if we are getting a question on RRT, definitely you can again create some of the templates or the domains like indications, principles, then what the different the principles on the basis of solute clearance, fluid management, biocompatibility, dose of dialysis, vascular access, anticoagulation principles, monitoring and complications, and take home message. Now, these are the things I know you all have already revised. So I will be little bit quicker just showing you the slides. What are the absolute indications of the dialysis A, E, I, O, U? I hope you all know it. And what are the relative indications like sepsis with AKI, toxin removal, fluid overload, unresponsive to the diuretics. Now, what are the principles of the dialysis? Diffusion, that is dialysis, convection, that is hemofiltration. Now, diffusion, where solute moves across a semi-permeable membrane along the concentration gradient, and that is good for small solutes like urea, potassium. So you can easily do with the diffusion or dialysis. Now convection is hemofiltration. That means solutes are actually dragged with the water in the form of solvent drag, and that can clear middle molecules as well, little bit like bigger molecules than the small solutes. The rate at which this dialysis or the hemofiltration happens is the ultrafiltration into the sieving coefficient. Sieving coefficient for each solute, it has a different, and each membrane they have the sieving coefficient different for the each of the solute. Now the third important point, the principle is the adsorption. Adsorption is like solutes adhere to the membrane surface, and these are important for the cytokines, endotoxins, and most example like important example is auxiliaries or cytosorb or like the charcoal hemadsorption. Now, the solute clearance efficiency depends upon the blood and the dialysate flow rate, membrane surface area, and the pore size. And also, this there are like the two modes which we can do: ISD diffusion that I have told, and CRRT. In CRRT, convective plus adsorptive. And here we want to know the concentration in minus concentration out divided by concentration in into the constant factor. Efficiency of different solute clearance, small versus middle molecule. The dialysis adequacy is in the form of KT/V. And then the next principle is the fluid management. Just remember, in the fluid management, controlled ultrafiltration for the precise fluid balance. This is especially crucial in our ICU patients who are suffering from sepsis, ARDS, cardiogenic shock, where little bit of like the other side of the fluid management will be landing up in the pulmonary edema. CRRT would be a better idea when we want gradual and when we want the fluid removal to be having hemodynamic stability. So this is very important. Now biocompatibility. Again, biocompatibility means the interaction between the dialysis membrane and the patient's blood. Because if we are like exposing the patient blood to an external membrane or extracorporeal membrane or circuit that can trigger complement coagulation and inflammation. These are the membranes. Normally we have cellulose membrane, which is biocompatible and bioincompatible, that can activate the complement, cytokines, coagulation, and that can increase inflammation. Now the synthetic membranes are nowadays preferred, which are in the form of poly AN6 and there will be greater biocompatibility the synthetic membranes compared to the cellulose membranes that can decrease the inflammatory activation, improved patient tolerance. Some have also adsorptive capacity for the cytokines or endotoxin like the auxiliaries. So it can serve the both the purpose. Clinical relevance: reduce systemic inflammation, better outcome in the critical ill and septic AKI patient. Important consideration in the CRRT and prolonged therapy. So the take home for the biocompatibility, that synthetic is better than the cellulose membrane and that can lower the immune activation and improves tolerance. Now coming to the dose and vascular access in RRT. Dose for ISD 3 sessions per week, normally 3 to 5 hours each. CRRT, as per the KDIGO 2012, the effluent dose should be 20 to 25 ml per kilogram per hour. The standard, like the landmark trials like Renal and ATN trial, they have found that higher dose is not equivalent to the survival benefit. So don't go for more than 30, 35. Adequate dose when we can say if there is optimal solute, clearance, fluid control, and not just higher intensity. Rather, we can say less is better. I would not say more, rather it is better. But yes, we have to be judiciously decide the dose. Now coming to the vascular access, any RRT if you are planning, we should have a proper vascular access. Now that can be again divided into temporary and long term. Temporary, it would be double lumen catheters and IJ femoral. Try to avoid subclavian because we all know the limitations or the side effects or complications of putting the subclavian dialysis catheter. Long-term catheters are tunneled cuffed catheter, and in long term, like when the patient is on IST for long time, AV fistula graft for the CKD patient. Now the key principle is we have to have adequate blood flow in the form of more than equal to 200 ml per minute, and also we need to minimize infections and preserve the long-term access site. Now, anticoagulation principle, we will be discussing this anticoagulation multiple times today because there is a separate question also, antibiotic during CRRT. The purpose is to prevent circuit clotting, maintain the clearance and prolong the filter life, which is very important. And the options we have is systemic heparin, most common, cheap, easy, but there is increase in the bleeding risk because it is systemic anticoagulation, and with heparin, sometimes our patient can develop heparin induced thrombocytopenia. Now, regional citrate anticoagulation, that is preferred in CRRT, and we all know the reason why we want citrate in our patient. It can chelate the calcium, and that would be having the local effect. So this is something regional. So remember the terminology. Regional means it would be only limited to the circuit. It will not have any effect on the patient's blood or in the systemic way, and this can have decrease in the bleeding. It needs calcium monitoring, and we need to be little bit cautious in the liver failure, severe lactic acidosis, patient on high vasopressor and acidosis. What are the alternative anticoagulation we have? Low molecular weight heparin, this is predictable, but yes, in AKI this can accumulate. Prostacyclin, which is antiplatelet used in the high bleeding risk, hypotension risk is there. Nafamostat, which is normally they have used in Japan and some of the Asian countries, but it has short half-life and we don't have in India. No anticoagulation is again one more modality when in a very high bleeding risk, because of if we want to finish the dialysis with shorter span, so we don't need anticoagulation when our bleeding risk is very high. Now, monitoring parameters in our CRRT, we can write on certain headings. Now, these are electrolytes. We need to be very cautious. Acid-base balance. We have to monitor the ABG, the lactate, the bicarbonate, the hemodynamics, like the BP, MAP, heart rate. We need to be very cautious if the patient develops hypotension or there is a volume shift. Circuit monitoring in the form of inlet and outlet pressure, TMP is transmembrane pressure. Whether it is the patient is having clotting or filter failure, filter life, which is again one more monitoring whether our filter is getting clotted easily. Membrane fouling is there because of this protein deposition. The pores are actually getting like clogged, and we should be having at least target of more than equal to 24 to 48 hours of filter life in our CRRT. Anticoagulation monitoring, if you are using heparin, it should be activated clotting time, and in case of citrate, it should be ionized calcium. Now the complications of any RRT, definitely you can always write hemodynamic instability, electrolytes for shift. Electrolyte, it would be all mainly related to the hypophosphatemia, hypokalemia, hypomagnesemia, hypocalcemia, especially with citrate. Most common electrolyte maybe we can say during the CRRT is hypophosphatemia, and this is also labeled as dialysis trauma. So in the exam, they may ask you, keeping all the complication related to dialysis, as a broad term or umbrella term, dialysis trauma. So don't be very surprised. It is just like another trauma in our ICU practice, like volume trauma, barotrauma. In case our dialysis patients are also having some of the complication, you can always write a short note or a long note on the dialysis trauma. Bleeding, so all these complications you can keep under the dialysis trauma. Infection, vascular access related sepsis, disequilibrium syndrome, because of if you are going for acute ischemic heart the heart disease, or like you can develop cerebral edema because there is actually rapid shift or disproportionate shift of urea from the central or the cerebral circulation to the systemic circulation. Air embolism, filter clotting, circuit related alarms. Now the take home message, at least for the RRT, if you are getting a long case, long question, RRT in AKI is life-saving bridge, not the cure. You have to understand the principles, indications, dose, and the complication. We need to choose the modality of the RRT. Again, if we are getting a question straightforward CRRT, like as it was asked in the DNB anesthesia, so we have to also discuss about the different modes. I will be discussing in the subsequent question. The choice of the modality based on the patient's hemodynamics, resources, and goals of care. Now, question straightforward. This is again from the DRNP critical care, but this was asked in the DNB anesthesia as well. So, CRRT, what are the headings? Definition, rationale, types, mechanism, indication, advantage, circuit component, monitoring, dose delivery, limitation, summary. So lot of things we can write, but yes, as always, I advise you should be first framing your like a subsection so that each section can have at least 4 or 5 lines you can write. What do you mean by CRRT definition? It is continuous extracorporeal therapy for solute and removal over 24 hours. It is never done for 10 hours, 12 or 14 hours. This is designed for hemodynamically unstable ICU patients where ISD may cause hypotension. What are the types? I have told you that I will be discussing. So these are some of the types of the CRRT. Which is hemofiltration, action based, where based so DE, CV variant hemodilution, where convection fusion is filtration, that is only for the fluid removal in acute decompensated heart failure, which is diuretic resistance. We don't want anything except the fluid removal. What are the mechanisms? I have already explained. I am not going into detail. The indications I have already written, but yes, in case of you are getting a question, so you can always write at least the headings. So that's why I have kept these things, though I know that you already know it. Like indication for CRRT along with standard ICU indication, you need to remember or write in the examination traumatic brain injury with cerebral edema. This is one of the standard gold standard indication. Acute liver failure with cerebral edema, and also post cardiac surgery, cardiogenic shock, transplant patients where you need to have better hemodynamic tolerance and fluid control. Now, what are the advantages of CRRT? Already we have discussed and we all know, but yes, this would be something which you can write in one of the section. What are the circuit components? Again, you need to remember that there are certain technical terms you have to write in the examination. One starts from the vascular access, blood pump, the tubing, hemofilter or dialyzer membrane, replacement fluids, dialysate pump, effluent collection bag, anticoagulation system in the form of heparin or citrate. The monitoring, when if you are getting the monitoring of CRRT, you just divide into two types, patient and circuit. In the patient, write about the vitals, hemodynamics, fluid balance, electrolytes, acid base. In the circuit, it would be pressure. All the pressures you can write, the access pressure, the filter pressure, the return line pressure, the filter life, anticoagulation parameter I have already told, APTT and calcium. So lot of time you will be just like listening to these words repeatedly through this nephrocritical care, but in the examination when you are right, you have to summarize it well. Now dose, in case of CRRT, it's always KDGO 12, the effluent rate should be 20 to 25 ml per kilogram per hour, and that includes dialysate plus replacement fluid plus net ultrafiltration. The three things are combined together. Now, delivered dose, you normally prescribe 20 to 25, but the delivery normally happens less than the prescribed dose due to a lot of interruptions like filter clotting, procedures, downtime, and this must account for the downtime when calculating actual delivered dose. So in real life, normally we normally prescribe it to be around 25 to 30 to at least reach 20 to 25 at the end. If you are writing 20 to 25, because of this downtime, we get it less than 20, which is not at all optimum. So our patients are not getting the benefit of CRRT. And as for evidence, the renal and ATN trials, they have shown that higher intensity to the tune of 35 to 40 ml per kilogram per hour doesn't improve any survival. And the target or our focus should be on adequately delivered dose, not higher intensity and frequent monitoring. Limitation of resource, the CRRT resource intensive, all the ICUs have not got that expertise. Again, the cost is the biggest factor. The nursing has to be very optimum or smart enough. Machines have to be there in the hospital, in the ICU, so this cannot be always available in the resource limited settings. Frequent circuit clotting will be a big problem. Electrolyte or trace element depletion, like I have already told, hypophosphatemia, hypomagnesemia, the patient will have difficulty in weaning. There are ECG changes, all these things can happen. And again, no proven mortality benefit versus ISD or SLADE, renal and ATN trial. So again, you cannot always say that these are the situation where if you do CRRT, there would be a definite proven mortality benefit compared to the SLADE or sometimes also ISD. So definitely we have to be very sure in which patients we are actually prescribing. Now coming to the summary, it is a modality of choice in unstable ICU patients with AKI, mainly the traumatic brain injury with cerebral edema or acute liver failure with cerebral edema, provides gentle continuous clearance and precise fluid control, but the limitation, definitely we need to be very precise in our decisions. Now coming to the fifth question, they sometimes the examiner would be expecting prescription of CRRT. I want to know how many people are there with me now. Thumbs up. Whenever you say that yes, we do not want now further, I would be stopping. Maybe later on we will be recording and sharing with you, because I don't want to just talk and there is nobody on the other side. So that feeling is something I am actually very fearful to. And Abnit, please let me know when the number reduces to less than 10. Okay. So prescription of CRRT, this is again a very important question. And as a clinicians also, when you clear your DRNB in the real life also, the clinicians, the hospital, the relatives, they expect you to write one prescription of CRRT. So indication and goals, vascular access, modality, dose, replacement or dialysate, ultrafiltrate goal, anticoagulation, monitoring, documentation. These are something which you need to be very thorough when you are writing one prescription of CRRT. Now, the indications I have already told, the goals also, because for starting dialysis, at least as a treating clinician, you should be very thorough that yes, this patient needs dialysis or not. So that's why you have to be very clear with the indication and the goal what you want to get after the dialysis. Whether you want to maintain the hemodynamic stability, whether you want to just remove the fluid in the form of scuff, whether you want to clear the urea creatinine or phosphate or potassium, or the regulate the acid base balance. What is actually your target? You need to be sure before going ahead with any extracorporeal therapy. And indication again, whether it is hemodynamically unstable AKI, fluid overload, sepsis with cytokine storm, where you want to remove some cytokines. Cerebral edema part is actually very concerning for you, whether it is TBI or ALF or extracorporeal toxicology. You want to remove some toxins. So you need to be very thorough, and that's why your prescription will be also tailor-made. Now, vascular access would be the second thing. You need to very much clearly write on your prescription whether you want to have IJ or femoral catheter, whether it is double lumen, what would be the size of the catheter, and we need to remember that femoral side, the longer site catheter is actually needed. What should be the flow target? You should have at least more than equal to 200 ml per minute blood flow for effective clearance. The checklist also, the line should be ultrasound guided, aseptic insertion, and securely fixed. What will be the modality? I have already told about what are the advantage of different modality, but in the prescription you have to write what do you want, whether it is CBP-SD, CBP-SDF, SCUF or CBP-H, and depends upon the indication. That's why I have told you that you need to know what is the indication from the very beginning so that you can write about the correct modality. And these are the primary process and the flow components and what is the mechanism. So this is one the very important where you can see the different modality mechanism behind flow component. Those I've already explained because I have told you, you will repeatedly look at these lines or the words, but this would be very much essential to just have a buzzword in your mind at the back of your mind. Now, QB and QD. So this is very important. QB is the blood flow rate. QD is the dialysate or replacement fluid. Now, QB already I have told usually is 120 to 200 ml per minute. You have to keep it lower in unstable patients, but higher for efficient clearance. Too high QB with low effluent, your filter would be not very much efficiently used because you are making your blood flow too fast. Too low QB, risk of clotting because the blood will be clotted within the filter. Now, QD or replacement fluid directly contributes to the prescribed effluent dose. So, split between the pre and the post filter replacement depending upon the hemodynamics and filter life. You want to add something in the pre and also divide, distribute between the pre and post filter replacement so that you are not getting the filter clotted also, and also post filter also there would be at least you are getting it diluted. Usual should be 15 to 25 ml per kilogram per hour effluent dose where you are actually making it dialysate and replacement. And effluent dose, I have already told it is actually dialysate plus replacement plus net UF. And this net UF is for fluid balance, not solute clearance. So we are not directly targeting net UF for the solute clearance. Rather, it is dialysate dose. Now coming to the replacement fluid or diluted fluid, pre-dilution that would prolong the filter life I told you, and but the side effect is or negative or flip side is it would decrease the clearance. Now post dilution it would be increasing the clearance, but there would be increase in the risk of clotting. So that's why we normally distribute your replacement fluid between the pre and the post so that both of the best worlds would be happening. And now the dialysate, it would be bicarbonate based preferred, better acid base control, and special consideration when you need something like potassium free or phosphate supplementation, something like if you are to treat the hypophosphatemia. Now some of the clinical scenario: septic shock with high catabolism, what would be your target, what would be your QB, what is your QD, how you are splitting 50-50 between dialysate and post filter replacement, what would be the modality of choice, and what is your rationale behind prescribing in this way. Now hyperkalemia or toxin where you are targeting or removing the small solute clearance is priority. So your target is this, QB is 180 to 200 and QD is higher dialysate flow in the form of CBP-SD. In sepsis, you are preferring CBP-SDF, where little bit of the cytokines are also getting cleared. But in case of hyperkalemia or toxin, CBP-SD because it is removing the small solute. So SD diffusion is actually which is favoring the small solute removal. replacement minimal or pre-filter if later cutting is risk. Now the another point C is hyperammonemia or site where you are actually targeting the middle molecule clearance, and here your convection is actually optimum. Now the fourth is hemodynamically unstable and high clotting, where you want to have uh, more replacement fluid in the form of pre-filter replacement that would be prolonging the life. And the target is again 20 to 25 ml per kilogram per hour. Now the next prescription find like the section would be ultrafiltration goal. What would be your target fluid balance? That would be individualized. Usually the net ultrafiltration should be 1.1 to 1.75, which sometimes you can write 1 to 2. And higher UF rate, if you are keeping higher ultrafiltrate rate, risk of hypotension and decreased organ perfusion would be there. And how you choose your ultrafiltration, that has to be guided by the mean arterial pressure, the vasopressor requirement, the in your patient focus. Now, next one very important is the anticoagulation. In the prescription about the anticoagulation, whether you are using heparin or RCA or any other alternative like low molecular heparin, prostacyclin or nafamoprast, or sometimes you are not advising any anticoagulation, that also you want to clearly write in your prescription that yes, this need anticoagulation. Whenever you write prescription, you are the clinician, so there would be some nursing or dialysis technician who would be monitoring the patient. What are the things to do, whether it is patient related, circuit related or anticoagulation related. I have already told about the various things. And what is the delivered dose at the end, whether you are whatever you are writing prescribing, and what is acting at the bedside, documented well. Now the last part would be daily to be clearly mentioned in these forms, and always ensure good communication nursing or ICU team. Now practical way to write the prescription, instead of just 25 ml per kilogram per hour effluent, you can write the 25 ml per kilogram per hour. Actual it will be around 22 to 23 downtime, your QB, your QD, and and adapted to the clinical scenario. And we already know that major trials, they have not shown any benefit if you are exceeding your 25 ml per kilogram per hour. So this is dynamic. You should be looking at the patient. Don't copy paste from the internet and write it on the your nursing chart or doctor's chart. And adequate delivered dose is more important than the prescribed dose. RCA, anticoagulation of choice unless contraindicated, and daily reassess for fluid goals, dose and continuation. And remember, already I have told CRRT is a bridge, not curative. So it have to be supported until renal recovery or transition to IST is there. Now coming to the anticoagulation CRRT or RRT, already you know, I'm just keeping the need of the anticoagulation option, systemic heparin, RCA, other strategy, contraindication, what are the monitoring complications as per the KDIGO, what is the recommendation related to anticoagulation, and the take home. This is an important question. Sometimes they ask it, but if you know it, you can easily score 8 or 9 out of 10 mark. What is the need of anticoagulation? I think already we have discussed in our previous questions. And where it is very important in CRRT, maybe IST we don't need anticoagulation. SLADE yes, but again SLADE can be done without anticoagulation also. But it is very important in CRRT where continuous flow predisposed to the clotting, and your goal should be to balance between the circuit patency and bleeding risk. What are the options? Again, I am not going into very much detail, already explained. Systemic, regional, no anticoagulation. Remember in these forms, systemic heparin, again, what would be the most common systemic heparin? This is unfractionated heparin, bolus plus infusion, Dose should be 5 to 10 unit per kilogram per hour. You can also give some bolus. Don't also do or give infusion. Pros, it is cheap, widely available. People are more conversant with the use of systemic heparin. The con is bleeding risk because it is systemic anticoagulation, and sometimes it also causes heparin induced thrombocytopenia. How to monitor? Yes, APTT or ACT. RCA, as per the KDIGO guideline, this is the preferred in the CRRT. The mechanism is, we all know, it is a local anticoagulation. Systemic calcium, sometimes if it is low, it has to be replaced by IV, the calcium, or through the pump. Now pros, prolonged filter life, less bleeding risk, and the monitoring, you have to monitor the systemic plus post filter ionized calcium and total by ionized calcium ratio. So this is the monitoring that you need to be very thorough if we are getting it in our CRRT. The contraindication I have already told, if it is severe liver failure on high vasopressor, shock with lactic acidosis. What are the monitoring in RCA? Again, systemic patients ionized calcium, I have already told, 1 to 1.2 should be your target. You should check the ionized calcium every 4 to 6 hours, and that would be guiding you the calcium infusion rate. Post filter ionized calcium, that is free filter sample, target should be less than 0.3 millimole per liter to ensure that anticoagulation is there, and check every 6 to 8 hours once stable. Now total calcium by ionized calcium ratio is more than 2.5, that would be suggesting citrate and accumulation. Now this is something which we do not want because it is now going in favor of citrate toxicity. Now you have to check the citrate level or calcium level daily or earlier if clinical suspicion is there, whether your patient is now developing more of acidosis, rising lactate and refractory hypocalcemia. That means you are going in like line of citrate toxicity. Now the systemic acid base status in the form of metabolic alkalosis. If a metabolic alkalosis is there, if your liver is perfect, then that means excessive citrate is actually converted into the alkalosis or bicarbonate. Now if it is like the metabolic acidosis is rising and you are getting rising total calcium by ionized calcium, that means citrate is accumulating, and you are like the monitoring should be every 6 to 12 hours. Electrolytes, yes, there is high chance of risk of depletion of sodium, potassium, magnesium and phosphate. So check daily or more often in unstable. Liver function test, yes, at baseline we need to have one baseline LFT and lactate, and you need to be very much vigilant if you are continuously getting that citrate accumulation is resulting in rising lactate, acidosis and high calcium by total calcium by ionized calcium. Other strategies, yes, these are the terminology that you need to remember, and thus pros and the cons of the different anticoagulation strategy. What are the contraindication to anticoagulation? Already again from the discussion that we had, systemic heparin has its own contraindications, RCA has its own contraindication, and as a general, using any anticoagulation in case your patient is having uncontrolled coagulopathy and high bleeding risk, definitely you should not use. What are the monitoring you should do? Already explained. These are some of the systemic heparin, RCA, circuit pressure, because if your filter is getting clotted because of inadequate anticoagulation, then definitely you will be getting rising TMP. Bleeding signs, if you are actually having systemic anticoagulation more, so your patient will be bleeding from different mucosal surfaces, hematuria, GI bleed. And what should be your monitoring parameter? Post filter ionized calcium less than 0.35 and systemic calcium is 1.1 to 1.2 millimole per liter. What are the complications? Again, all these things are we all know. Just remember heparin, RCA, low molecular heparin, and some of the anticoagulation like prostacyclin, they can cause hypotension, and there are certain limitation of using nafamostat, which is not there in most of the other countries apart from Japan. And also hypocalcemia, remember citrate toxicity, the examiner maybe in the theory, in the practical or in the viva, they would be showing you one ECG where there is a long QT, and they will say that this patient was on plasma exchange or the CRRT. So they would be expecting some of the complication in the form of hypocalcemia that is resulting in arrhythmia. So this is, and as per the KDIGO recommendation, so RCA is the preferred anticoagulation in CRRT. Systemic anticoagulation with unfractionated heparin if your RCA is not feasible, and no anticoagulation if there is high bleeding risk. And anticoagulation strategy must be tailored to patient and ICU resources, because RCA is not feasible in most of the ICUs, at least in the resource limited setting. So take home message, something which you can summarize in your examination, starts from the different types of anticoagulation, end with the monitoring complication and how to manage. How many of you are with me? Any questions at this point of time? Are these presentations are at least no, you feel you are able to understand, because I am trying to cover up, but yes, it should not be slowed also, because most of the things I want to only sensitize you so that in the examination you can just quickly write, not like Mr. Bean, but like Pele. Okay, so drug dosing in RRT, the next question, very important. Just heading, you need to know the PK principle, pharmacokinetic, the different drug properties, whether what are the antibiotics, what are the antifungals, that you need to be very clear whether you are actually adding extra dose or not. Filter factors that can affect your drug dosing, whether what are the adjustment that you need to do, the antibiotics, antifungals, antivirals, anticoagulants, analgesics. What is the role of TDM? TDM is therapeutic drug monitoring, and guidelines. What are the guidelines say and the key summary? PK principle in CRRT, ADME, or ADME. What is ADME? Can anybody just post in the chat box? I want to know that it's are like all of you are actually completely muted. In case of PK, ADME. What is ADME? Can anybody tell me the full form? It is already written here: absorption, distribution, metabolism, and elimination. So always whenever a question comes with the pharmacokinetic, you can write that. CRRT adds an extra renal clearance pathway. It is not only the kidney and the liver in our intra, in our in vivo, plus also in vitro. Hydrophilic drugs more affected, that is aminoglycoside and beta lactams, because these are hydrophilic and that would be excreted through the extracorporeal therapy. Lipophilic drugs, less clearance, more tissue bindings. VD, which is volume of distribution, protein binding, clearance. That also has some effect on the total drug doses and the efficacy of the drugs. Higher volume of distribution or protein binding, that has less removal, and that has also to be understood if you are actually thinking to do dialysis. Drug properties affecting clearance, standard from our pharmacology class. Molecular weight, small molecules easily cleared by diffusion. And whether it is you need to know about hydrophilic, small drugs cleared easily. Protein binding, only free fraction removed. And like phenytoin bound, less clearance because high protein bound. Volume of distribution, if large volume of distribution, less removal, for example digoxin. Hydrophilicity, hydrophilic drugs are cleared more, that is aminoglycoside. Filter factors, membrane pore size and type. High flux adsorptive membranes, higher clearance, because you have along with the usual principle, you have also adsorption method, so definitely it would be cleared easily. Mode of CRRT, CBPH is convection, diffusion is CBPHD, small molecules, CBPHDF, both. Effluent dose, you can also write about whether you are going for high effluent dose, that would be definitely affecting the drug clearance. Dose adjustment based on both renal function plus CRRT clearance, and also account for the downtime or interruption, delivered versus prescribed dose. Adjust the loading versus maintenance doses separately. Often you need to have higher than expected maintenance due to CRRT drug loss. And adjustment, whether you are going for under or overdosing, you need to avoid both the two things. It's not underdosing, also overdosing. And effluent dose should be equal to the clearance. Now, what are the antibiotics that you need to be thorough about in CRRT? Beta lactams, because they are time dependent. What you will do? Extended or prolonged infusion, and in CRRT you should be increasing the dose. Aminoglycoside, it is concentration dependent, so give the full loading. Don't be afraid of giving the full loading if your patient is on CRRT. Adjust maintenance, and always if you think about, give post dialysis dosing. Repeat again one more dose. Vancomycin, significant CRRT clearance. So again, we all know the limitation of vancomycin, the trough level and the crest level would be little bit different or difficult to know. So frequent, if your hospital has therapeutic drug monitoring, so go for it, and higher doses you should be giving. Daptomycin and linezolid removed variably, dose adjustment often needed. Coming to the antifungal or antiviral, so you can see here fluconazole well cleared, low protein binding, so you need to increase the dose. Voriconazole, posaconazole, high protein binding, large volume of distribution, so less affected. So you don't need to increase the dose. Acyclovir or ganciclovir, they are cleared extensively, so dose reduction needed, plus monitor the toxicity, because you need to be very clear about what you are actually giving as antiviral. Amphotericin, just remember this is one antifungal which is not cleared in the CRRT circuit, maybe because of this liposomal form. Anticoagulants or analgesic, again, heparin, low molecular heparin, unpredictable, monitor the SCT or APTT. Citrate, they are removed in CRRT, but systemic effect is minimal. Opioid, morphine metabolites accumulate. Fentanyl or remifentanil is safer. Paracetamol cleared by CRRT, but they may need we need a higher dose because this is cleared by CRRT. Now the role of therapeutic drug monitoring, essential for the narrow therapeutic index drugs like vancomycin, aminoglycoside and phenytoin. You don't want to err on the difficult side. Guides the dose adjustment in variable CRRT settings, helps balance toxicity. And in the final, key summary, CRRT profoundly alters the drug clearance, and we need to be very clear on the drug filter and also CRRT settings. Now, hydrophilic low protein bound drugs are most affected. Effluent rate, key determinant of the clearance. So we need to be very clear, and always use loading doses. Don't be compromising on the loading dose. Maintenance guided by CRRT plus TDM, whether it is volume the lipophilic or hydrophilic or volume of distribution, and individualize the prescription daily based on the patient CRRT delivery and drug monitoring. Now, challenges in the CRRT, that was also another question. Again, you all know the CRRT challenges. Again, I will be just showing you the slides because this would be again repetition of many things. So you can always write in certain headings technical challenge, filter or circuit challenge, vascular access challenge, anticoagulation challenge, hemodynamics, electrolyte, nutrition or drugs, cost or resources, prevention of different the challenges, and take home message. Technical challenge, again, this we all know. Complexity of the machine setup and operation, frequent alarms, require trained nursing staff. Downtime, because if we write something but what is actually happening at the bedside, how much is actually getting translated to the patient's recovery, that is a little bit difficult to know. It needs continuous power and monitoring, which is sometimes in resource limited setting difficult. Filter or circuit challenges, filter clotting, protein fouling, air or blood leak, circuit kinking, pressure alarms, frequent interruptions that will lead to the underdialysis. Now coming to the vascular access issue, vascular access is malposition, or it is like having thrombosis, or there is infection, insertion complication. If we are starting with one bleeding inadvertently, puncturing the artery, pneumothorax, definitely these are some of the challenges or complications of CRRT. Site infections, catheter related bloodstream infection, CLAPSI, inadequate flow leading to decreased clearance and increased circuit clotting, central venous stenosis with prolonged use. Anticoagulation challenges, I hope we have already discussed in detail. Hemodynamic challenge also, along with hypotension, there is also happening cardiac stunning in patients who starting SLADE or CRRT immediately. Intracranial pressure instability in traumatic brain injury or ALF, and how you want to closely titrate the ultrafiltrate and vasopressors. Electrolyte challenges already I have explained. Just remember the basic fundamental and how you are going to treat them. Nutritional and drug challenges, yes, loss of water soluble vitamins, amino acids, hypoalbuminemia worsened by protein loss, altered pharmacokinetics of many drugs, and we need to have careful drug dosing plus TDM. Otherwise, we can continue with the CRRT, but the patient will not recover because of the inadequate or inefficient treatment of the sepsis or septic shock. Now, some of the nutritional or drug related problems, nutritional, I have already told, amino acids, peptide, they lost in the effluent, Water soluble vitamins are easily cleared, so you need to supplement water soluble vitamins in your ICU, IV, externally. Trace elements, again we need to supplement albumin, larger protein, though it is having minimal loss, but yes, if you are using high flux or adsorptive membranes, that would be also excreted. Now, drug related issues I have already told in detail. Clinical implication, you need to give higher protein, like if your patient is on CRRT, vitamins, trace elements, daily drug dosing review, and TDM if you are like having narrow therapeutic index agents. Cost and resource challenges, already told. There are a lot of things which we need to be very clear in our mind before starting the CRRT program. What are the prevention and mitigation strategy? Definitely we need to have a protocolized machine setup, anticoagulation, ultrasound guided vascular access, treat asepsis, individualized ultrafiltrate and dose prescription, regularly monitoring electrolytes and supplementing it, and multidisciplinary approach where intensivist will be at the center and nephrologist and ICU nurse as well as dialysis technician will be the periphery. Take home message: CRRT is life saving but resource intensive. There are a lot of technical, vascular related, anticoagulation related, hemodynamic related, metabolic and nutritional challenges. Most complications are actually predictable and preventable if you are clear in your CRRT prescription and also with confidence of your team. You can clearly have CRRT outcomes properly. How it going to prevent? Vigilant monitoring and protocols. Success depends upon team training, standardized protocols, and vigilant monitoring. Do you need all any break for 2 minutes, 3 minutes, or it's okay? If you want me to continue without any interruption, it's okay, or we can have 2 minutes break. We want to continue. Okay, perfect. So question number 9 is early versus late RRT. Now, this is again another question that was asked. So we can have, what do you mean by early? What do you mean by late RRT? What is the rationale behind early RRT? What is the rationale behind late RRT? The evidence, the comparison of between the early versus late as per like the recent landmark trials, the current consensus, and the conclusion. Now, what do you mean by for the life-threatening complications happen and the late when absolute indications present? Now, if you want to know what is the rationale, early means to prevent the further complications related to azotemia or hyperkalemia or some or other like the fluid overload. Now, late avoid unnecessary RRT related risks. If you are subjecting our patient to early RRT, maybe most of the time we could have actually avoided with our conservative management with treating the disease as such rather than subjecting to one extracorporeal therapy. Now, this is the RRT initiation landmark trials in critical ill patient. You see from 2002, 2013, then came the Elaine trial. I would be discussing that also. Then Kiki trial, Ideal ICU trial, and Start AKI trial, then AKI 2 trial in 2023. Now you can see I am not going into detail, but yes, in case if you want to just have a short note on different landmark trials of early versus late, so these are some of the standard trials you can always write about: AKI, Elaine, Ideal ICU, Start AKI. And this is in one slide about the different like things about the Elaine, Akiki, Ideal ICU, Start AKI, and the recent one Lancet published Akiki 2. So this is something which you can always remember. Now, this is only one trial which has suggested that if you start early, so the mortality is actually significantly lower. Ellen trial, but this is more confined to the surgical ICU patients and early within the 8 hours of critical stage 2. And they found that decrease in the 90-day mortality to 39% if you start early, and late it was 55%. Then the Akiki trial 2016, the first one, medical ICU, early versus delayed, absolute indications, no survival benefit. Rather, 49% of the late group, they never required RRT. Okay. Now, ideal ICU, septic shock with AKI, again, no mortality benefit with early initiation. Start AKI 2020, more than 3,000 patients, multi-center, and no mortality benefit, increased dialysis dependence in the early group. So all these are negative trials related to the early the AKI if you are going for dialysis early. Now, some of the meta-analysis also, they have also suggested like 2021 to 23, no consistent survival advantage, and delayed actually avoids unnecessary RRT in 30 to 50%. So at least early you should not be going. Now, early versus delayed. Early RRT means before conventional indications like life-threatening hyperkalemia, pulmonary edema, severe acidosis. Potential benefit, you are instituting early RRT, so that would be helping in early removing the toxin and the solute, prevent the complications. Some of the trials that I have already told, Elaine trial that showed high benefit in high risk surgical ISO patient. Delayed RRT starts only when the standard indications are present or patient deteriorates. Advantages, it avoids unnecessary RRT seen in 30 to 40% of delayed arms patient, lower risk of RRT complications, and there are a lot of trials that showed no mortality benefit in early initiation. Now, current consensus is watchful waiting plus close, and early initiation may or refractory metabolic the derangements where you can start your the early dialysis, but yes, most of the cases it is not like right now you will be subjecting your patient to the early dialysis, because it would be unnecessarily bringing some of the complications of the early dialysis. Now, guidelines also you need to see as per KDIGO 2012, initiate when life-threatening complications develop, no universal benefit to early RRT, not creatinine versus urea threshold, and individualized decision. So, conclusion, early RRT selected benefit in high risk patients, delayed safe avoids unnecessary therapy, and adopt watchful closing, watchful monitoring, and waiting. Now, next question, it would be again related nephrocritical care, that is plasmapheresis and plasma exchange, regime, process, indication, complications, evidence. What is it? It is like extra corporeal blood purification technique. Yes, I need some of the thumbs up of these questions to keep me motivated. Like maybe I would be a little bit demotivated, but it's not like that. I want to give justice to our class, and this is the one class, last class before we will be live with you, because neuro part would not be possible for us to like give you live. We don't want to also. You can give two thumbs up also, that would look like you are having like 30 or 40 people, though I know only 18 or 20 people are there. So if you do multiple thumbs up, that would look like there are more people. So we will be definitely recording the neuro part and sharing with you, so that the whole comprehensive critical care will be with you for next 25 days or so for your theory exam. Now, coming to the plasmapheresis or plasma exchange, again, it is one form of like extracorporeal blood purification technique designed for removal of large molecular weight substances. So, plasmapheresis is not for small molecules. So, more or less, it would be for large molecular substances. And what do we actually do? We separate the like plasma from the blood cells by centrifugation or membrane filtration. And sometimes we will be again reinfuse of cells with cleaned autologous plasma or donor plasma or another replacement colored solution like albumin, FFP or cryoprecipitate. So this is termed as plasma exchange. Exchange means we are taking something and we are giving something. But plasma pheresis is when we are taking the plasma only from the patient, right? And then purifying it. Now, in common usage, the term therapeutic plasma exchange and plasmapheresis are actually used interchangeably. So people normally use it, plasma exchange, plasmapheresis, but you need to be little bit clear that they are not actually so much similar. Now, therapeutic plasma exchange, I have already told, where large volume of plasma is taken, and if you are not actually replacing, then significant hypovolemia resulting in vasomotor collapse would occur. So it must be replaced with some form of replacement fluid. Now, Plasmapheresis, where we are actually taking smaller amount of plasma, typically less than 15% of the patient's blood volume, and many treatments involve a process of cleaning of the patient's own plasma, and then that has to be returned to the patient. So here we do not actually always require replacement of the removed plasma, like sometimes. And many treatments involve a process of cleaning and its return, but this doesn't require always like we need to be replacing. Now, this is the circuit of the therapeutic plasma exchange, what we are normally doing. So just like your dialysis, but yes, here blood pump is there and you are separating the plasma here. There is plasma filter here, plasma separator, and you are getting the plasma pump here. Substitution fluid is adding here something if you want to have some replacement fluid, and then the waste is coming outside here, and then plasma separation, what is happening, that is now again going back to the patient. So you can just draw one diagram. The examiner would be at least clear that yes, you know what are the main pumps and the filters. What are the pathologic substances removed by therapeutic plasma exchange? Again, you can see here immunoglobulins, autoantibodies, lipoproteins, leukocytes, platelets, abnormal red cells, circulating immune complex, protein bound substances and toxins, and hyperparasitemia. Can you see? In malaria patient also they have tried to remove the hyperparasite, parasite level in therapeutic plasma exchange. Now coming to the applications, yes, just remember some of the indication in the examination. If you do not have time, you can just create one diagram like this and write about the most important. Don't forget to write about rheumatology, hematology, neurology, and nephrology. These are some of the, I think, most important indications that you should not be forgetting to write. Now, the indications can be divided into again absolute indication, where therapeutic plasma exchange is a recognized first line treatment, and relative indication, where it is recognized as a second line treatment. Now, what are the most important absolute indication? AIDP, we all know, Guillain-Barré syndrome, Goodpasture syndrome, hyperviscosity syndrome in the form of hypergammaglobulinemia like Waldenström microglobulinemia, catastrophic antiphospholipid syndrome, myasthenia gravis, NMD antibody encephalitis, TTP, acute liver failure. Acute liver failure, again, you need to remove the albumin bound and water soluble toxins. So these are absolute indications. Relative indications are autoimmune hemolytic anemia, chronic acquired demyelinating polyneuropathy, Lambert-Eaton myasthenic syndrome, and steroid responsive encephalopathy. There are also another indication which is rescue indication. Rescue indication means disorder for which therapeutic plasma exchange may be used in the ICU as a rescue therapy, despite we do not know there is having any strong evidence about its efficacy, like heat with progressive thrombosis, cryoglobulinemic vasculitis, pancreatitis with severe hypertriglyceridemia. We normally prescribe therapeutic plasma exchange, but yes, or plasmapheresis, but it is rescue indication. It is not having absolute or relative indication. Specific type of poisoning, paraneoplastic neurologic syndrome, SLE with severe vasculitis complications. Now, some of the formulas you need to remember during plasma exchange. What should be the plasma volume? 0.07 into weight into 1 minus hematocrit. Normally, we should be doing at least 1 to 1.5 plasma volume exchange per procedure. And the techniques, again, what you normally do is with the centrifugation devices used in the blood banking procedure. But in ICU, we can do with our normal dialysis machine. Venous access, again, as usual, we put the central line, and as per the American Association of Blood Bank, general recommendation is one exchange be performed every second or third day, each exchange consisting of 1 to 1.5 plasma volume, and we should be going for at least 3 to 5 procedures. Exceptions: in acute GBS, it may be necessary after initial exchange to perform TP 1 to 2 times a week until improvement happens. In TTP, it should be performed daily until the platelet count is normal for 2 to 3 consecutive days. Goodpasture syndrome, this should be again on daily basis for at least 2 weeks. And what are the replacement fluid? As I have told, maybe albumin saline or combination, or FFP. So that would be something which we can be giving through the replacement fluid. What is the evidence? TTP, GBS, ALF, sepsis and ARDS. You can always write about 2 to 3 strong indications. What are the complications? Again, I told you, whenever any procedure you are writing or you are being asked about the complications, start with the things that is involved in that procedure. Starting from the vascular access, then during the procedure hemodynamics, metabolic or electrolytes, then hematologic, immunologic or infectious. Because of hypogammaglobulinemia, what happens? There is increased chance of infection. Then you are using so much of FFP and albumin, maybe the patient will be having some allergy or anaphylactic reaction. During the procedure itself, air embolism, line disconnection accidents and trally, if you are using so much of fluid replacement, they can land up in trally, hemolysis, infection with FFP. In conclusion, this is a life-saving extracorporeal therapy in immune-mediated or hematologic disorders mainly. Role in sepsis or MODS is investigational. Always follow American Society of like the apheresis. That would be something which can guide us. How many are of you are with me? Okay, very nice. Okay, you all are with me. So next question again very important. We all like expect this type of question in our recent exam because recent advances extracorporeal therapies in sepsis is one of the red hot chilly question which can be asked in your exam. So again, rationale behind extracorporeal therapy in sepsis, modalities, evidence, guidelines, limitations, and conclusion. Now, we need to first understand what is the sepsis pathophysiology that would be helpful or that can guide us for like using extracorporeal therapy. In sepsis, what happens? There is a dysregulated host response, and that results in cytokine storm, endothelial injury, microcirculatory dysfunction. So both macro and microcirculatory dysfunction happens, and there is imbalance of the pro-inflammatory. Pro-inflammatory means IL-6, TNF alpha, and anti-inflammatory. A lot of anti-inflammatory mediators will be there. Now there would be also pathogen toxins along with these cytokines. There would be some of the endotoxins or exotoxins. They also amplify the organ injury, and that would be leading to the multi-organ dysfunction. So this is we need to remember. Now, what is the rationale for extracorporeal therapy? The extracorporeal therapy can remove the harmful mediators in the form of cytokines or endotoxins. They can restore the immune homeostasis. They can balance between the pro versus anti-inflammatory state, and they can also maintain the organ support in the form of solute or fluid balance and acid-base stability. Now, what are the modalities we have? Just remember there are certain modalities that is helpful in our day-to-day practice. One is hemoperfusion, polymyxin B, cytosurf, auxiliaries, then high cutoff or medium cutoff membrane, coupled plasma filtration adsorption CPFA, plasma exchange in the form of TPE, and hybrid therapies with CRRT. So this is something which we need to know, so that at least in the examination, if we are writing, we can like at least write about 3 4 lines about each one. Now polymyxin hemoperfusion, UFAS 2009, the mortality reduction was there in abdominal sepsis, but then there is another study came, Abdomix 2015, there is no mortality benefit. And Euphrates 2018, again you can see no overall benefit, possible effect in high endotoxin activity subgroup. So in the examination, at least you should remember about these 3 landmark studies and the different meta-analysis that have been conducted. They have shown inconsistent survival benefit. Now second one is the cytokine adsorption in the form of cytosurf. Principle is, what happens in the cytosurf? The hemoadsorption device with porous polymer beads, they remove the hydrophobic molecules like cytokines, myoglobin, bilirubin, and toxins. And the goal is to like attenuate the cytokine storm and restore the immune homeostasis. What are the indications? Indications are not always like the confirmed. So it is proposed or investigational. One is septic shock with high vasopressor requirement. Hyperinflammatory states we all have used during the severe COVID-19 time when we are not getting the adequate response. So we did it with like no anti-inflammatory drugs like steroid. We have used tocilizumab, and also sometimes we have used in cytosurf therapy. Pancreatitis, trauma, post-cardiac surgery, SARS. So here the problem is with pro-inflammatory cytokines. Sometimes we can also add with like no ECMO or CRRT. The evidence is rapid cytokine removal is documented in the form of IL-6 reduction to TNF alpha reduction. Small RCTs and registries, they have shown improved hemodynamics and decrease in the vasopressor requirement, but large RCTs, they have not given green signal for like having a proven mortality benefit. KDIGO or surviving sepsis campaign guideline, they have not recommended it as a routine practice, but yes, used in clinical trials and rescue therapy, or like the when you are in desperate situation. Coming to the complications or limitations, non-selective removal, because it is not only removing the problem or culprit antibodies or cytokines, rather it can also remove some of the good cytokines and also antibiotics, nutrients and drugs. Cost, availability, and again we have to start it in early hyperinflammatory phase. If we are starting it in the anti-inflammatory phase, when the patient is already entering into CARS. CARS is the compensatory anti-inflammatory response syndrome. Then we are removing some of the good cytokine at that time. Patient will not be able to actually recover from the second hit or third hit. So the verdict here is Cytosur provides cytokine clearance and hemodynamic stabilization in septic shock. But yes, survival benefit is unproven and best used in selected patients only and or in trial patients. CPFA is actually what happens. You are actually plasma is separated. It is undergoing through adsorption and hemofiltration. So both the two things are happening, and it is passed through resin cartridge that can remove the cytokines, endotoxin, inflammatory mediators. They can again be recombined with blood, then conventional CRRT for solute and fluid. So both the two things are happening here. Rationale: broad spectrum removal of both pro and anti-inflammatory mediators, and the aim is to restore immune homeostasis, support organ recovery. Evidence: some of the pilot studies have shown that it improves hemodynamics and decrease the vasopressor requirement. But compact 1 and compact 2 trials, they fail to show any mortality benefit, and these trials have actually been stopped early. So it is used mainly experimental wise, not guideline recommendation. Limitation: complex, costly, requires dedicated equipment, large plasma volume needed. So logistic challenge, we cannot get so much of plasma volume. It is non-selective, so risk of removing the protective molecule, that is the biggest side effects or complication of going with all these extracorporeal therapies for sepsis. And CPFA, that offers a broad spectrum extracorporeal immune modulation approach in sepsis, but RCTs are silent or they have not shown any survival benefit. Currently, it is limited to the research or rescue therapy. This is one of the picture of CPFA. You can see here how the plasma filter is first happening and then it is passing through the dialysis filter. Now, plasma exchange, that is also one of the other modality for extracorporeal therapy. The one article published in NEJM 2016 that improves transplant-free survival. There are small RCTs and meta-analysis. They show that decrease in the SOFA or mortality, but evidence is low certainty and investigational. As per the guidelines, if we will be just going through guidelines, surviving sepsis, they have mentioned there is no routine use of hemoperfusion, adsorption or CPFA outside trials. RRT, it is only for standard indication, not for cytokine removal, and plasma exchange only for specific immune mediated disorder as per the ASPA guideline. Limitations: yes, we cannot expose all of our sepsis patients which have so many the phenotypes, endotypes. So it is a heterogeneous population. We cannot give blanket therapy of extracorporeal therapy to this type of patients. Timing, dosing, and how long we have to subject our patient for extracorporeal therapy is unclear. It is having high cost, resource intensive, and again there are certain complications or risk associated of using these therapies. So in conclusion, yes, this is biologically plausible, but no survival benefit till date. Routine use not recommended. Maybe it can help in research settings or selected subgroups. Future, we may have to integrate the our the therapy with the biomarkers and personalized strategies. We need to have certain cutoffs of the cytokines that we are targeting to remove. Otherwise, there is no point of subjecting the patient to multiple times any extracorporeal therapy. So this is again something which is very important. Remember the headlines. If you remember, you can write at least about 4 to 5 lines, and any question you can answer. That is whole idea of conducting, organizing this type of crash course. From the nephrocritical care, maybe now the transplant cases are happening more, so the examiner may expect that how you are confident in the renal transplant management. So I am just trying to give a summary of renal transplant because it is not possible to give in detail. So it is a definitive therapy for end stage renal disease, the transplant. It improves survival, quality of life versus the dialysis. Dialysis is never much preferred because every time it has its own complication. The goal of renal transplant is to first survive with the graft, and then there should not be any infection and any complication related or during or after the procedure. Now, before going into the transplant related complication, first we need to optimize the pre-transplant patients with the immunological. Again, every time you write about a question, every subsection, again what you write, you need to again give or make it a subsection, so that it would be very structured and you don't need to write in complete. You cannot write a full sentence. There would be grammatical mistake, there would be something like how you would be writing so much. If I am talking now, if I will be asked to write all these things, then it would be like no, your exam would be there and we all be not able to finish your this comprehensive critical care crash course. As I am talking, I am able to talk. But if you wish me to write again what I am talking, it would be endless. So that's why you need to have a small sentences like this. So the examiners would be just looking at this slide or maybe your paper, and they would be knowing at least that yes, this candidate knows about most of the things. Maybe he has not or she has not written in full sentences, because sometimes you can save time by just writing immunological, HLA, cross match, panel reactive antibody. So it is self-explanatory. Infectious screen, HBV, SCB, HIV, TB, CMV, EBV. What you will write in if you write as a sentence, it is self-obvious if you are writing infectious screen itself. Comorbidities, diabetes, because renal transplant, diabetes, cardiac problem, obesity, malignancy. Now, immunosuppressive regime, yes, you need to know about what are the immunosuppressive. There are certain no, the standard classification. So for renal transplant, you have to know about the induction chemotherapy, maintenance chemotherapy, that is tacrolimus, cyclosporin, and MMF, azathioprine, steroid. These are the some of the buzzwords that you need to remember. Any exam, this would be coming. Balance between the rejection versus infection. So if you are overusing, it would be going into the complications, toxicity. If you are actually giving it in high dose, maybe patient will be immunocompromised and that would result in the infection part. And the patient, if you are not using in proper dose, then patient may go into rejection. Now, during all these renal transplant, like whether the patient is going into surgery or in your ICU, you should be trying not to have any infection. So preventive measures and monitoring. Prophylaxis, you can try with cotrimoxazole, valganciclovir, antifungals. Vaccination pre-transplant, vigilant post-transplant monitoring like CMV, PCR, BK virus, cardiovascular metabolic issues. You need to optimize all these things because that would be depending upon your long term patient care. Hypertension, diabetes, dyslipidemia, then CNI, nephrotoxicity. Monitor the labels. Your hospital, your lab should be equipped with getting all these lab reports on time. Now then, if you do it long term metabolic syndrome, definitely your patient will be better managed. Now, if you just go with other complications, yes, malignancy is one of the things that you need to be very cautious. Bone disease, steroid if you are using, then bone diseases can happen. Chronic allograft dysfunction can happen. As per the guidelines, you can remember with KDIGO and American Society of Transplant, if you are going with the proper direction, 1 year graft survival is more than 90%. 10 year survival is also improving with better immunosuppression. You have to carefully select your patient free of optimization during surgery also in ICU also, take care of the immunosuppression part and infection prevention. Lifelong follow-up has to be mandatory. So key summary: careful selection, immunosuppression, infection prevention, and lifelong follow-up is mandatory. Now the 13th number question is graft rejection. If graft has been rejected, then how will you identify and how will you are going to manage? So this is the last question in the nephrocritical care part. So definition and type, here we need to remember hyperacute, acute cellular, antibody mediated, and chronic rejection. Now, clinical presentation in case the patient is going into graft rejection: rise in the serum creatinine, decrease urine output, proteinuria, there would be some graft tenderness sometimes. What are the risk factor? If you are not going into proper HLA, means like no matching during the renal transplant, poor adherence with the chemotherapy, inadequate immunosuppression, some of the infection have happened like CMV or BK. How you are going to diagnose? You will be getting the creatinine to be rising. You can do the Doppler to rule out obstruction or is there any vascular anomaly or abnormalities. In case of confusion, go for the biopsy as per the Banff classification. You need to remember this. This is the gold standard. If it is acute cellular rejection, so pulse dose steroid, resistant cases anti-thymocyte globulin, switch to the cyclosporins. Then antibody mediated rejection, plasmapheresis or IVIG, because here we want to remove the culprit antibodies. Go for rituximab, bortezomib or eculizumab in refractory cases. Chronic rejection or like the different like the CNI related complications. So no effective treatment, supportive care and optimize the blood pressure and diabetes. Differential could be again cyclosporin induced toxicity, recurrent disease itself. The primary disease has again like no started like no floating, obstruction, maybe tubular obstruction or some other infections. Now prognosis and prevention: rejection episodes worsen, long-term graft survival and adherence, therapeutic drug monitoring and protocol biopsy. You need to have at least a structured transplant program in your hospital ICU to have a good outcome. Guideline: KDIGO 2020 transplant guidelines. You should be going with the updates of Banff classification. Now take home message for the graft rejection: identify early, rising creatinine is there, go for biopsy, try to identify the problem properly, different types, tailor the therapy, prevention via adherence, adequate immunosuppression. Now this is all related to nephrocritical care. So now we need to discuss about some of the miscellaneous questions which have been like at the end of the curriculum that we have shared with you. How many of you are with me? Do you want to continue with the miscellaneous questions, which are like maybe 5 to 6 questions? You can post whether you want it now or not. I can finish it maybe next 40-45 minutes. All okay? Should we go ahead? Okay, perfect. Yes, perfect. Uh, this would be quick because this is very practical and miscellaneous questions which you can write easily. Nephro part was slightly, if somebody has not worked in this type of settings, that would be difficult. Then the first question in the miscellaneous is scoring systems in ICU, role in outcome prediction. Very important. Any ICU, any NABH coming to your ICU, if you have witnessed, then they would be always keen on knowing what are the scoring system that is used in ICU. So for a like not final year trainee who is about to be consultant, so definitely this is expected by the examiner. So what are the purpose of ICU scoring system? Why we want ICU scoring system? This is very easy miscellaneous question, so I will not be expecting like no to be at least giving a pause. I will be just showing you the slides so that you can guess what should be my headlines if I am getting any question for like this type of things. So the purpose of ICU scoring system, that it should be quantify the severity of illness and predict the outcome, and it should be helpful to like no prognosticate the family, the patient. Decision making should be easier, and it should be helpful in our research and also benchmarking our care, our hospital, our ICU, at the national level. What is our standpoint? Now, what are the classification of ICU scores? So if you want to give again a structured classification, it would be as per the CBS. And some of the examples are Apache, SAPS, MPM, mortality prediction model. That can be also based on the organ dysfunction scores like SOFA, MODS, and LOTS. Condition specific, whether it is liver, whether it is like related to the sepsis, and then specialty. Specialties, it is trauma or it is related to emergency department. Now, what are the principle of scoring? Wow, these scoring systems have actually come. This is derived from large ICU database, and they use the physiological lab and the demographic variables, and there is regression or logistic model. It's not like that any more like the vitals they can add and they can create the scoring system that have been already subjected to rigorous the regression and logistic models, and as a result what has happened, that can predict pretty well the mortality, morbidity, and length of stay. Now, some of the important ICU scoring system you should know can come as a separate question, a short note, 5 marks also. Again, you need to remember in detail. Here, I am just giving you a snapshot. What is Apache score? Acute physiology and chronic health evaluation. It uses initial 24-hour ICU data. There are certain versions like Apache 2, Apache 3, and Apache 4. Most probably, your hospital must be having some Apache scoring in your day-to-day clinical practice. Apache scoring predicts hospital mortality, and this is widely used for benchmarking in research in registry maintenance. Now, the next important scoring system is SAP score. Now, what is SAP score? This is simplified acute physiology score. There is SAPS 2 and SAPS 3. The parameters that is used here: age, comorbidities, and physiology. This is one of the score that has actually predicted the mortality in multi-center studies. Now, the third one is the MPM score. MPM is mortality probability models. The data at admission, 24-hour and 48-hour. This is simpler and fewer variables are there. Normally, this is used for quality improvement and comparisons. The next one is the SOFA score. I know everybody knows about the SOFA score. SOFA score is sequential organ failure assessment score. So, 6 organ systems: respiratory, CVS, CNS, renal, liver, coagulation. It tracks dysfunction over time. Every day you need to do it so that you can get one trained rather than only on the first day or second day. Sepsis 3 definition, they have mentioned that SOFA score rise of more than equal to 2 can result in or guide you or at least predict that yes, the organ dysfunction has started. Now, other organ dysfunction source: MODS, LOTS, prognostication in multi-organ failure. There are certain condition specific scores also like MELD score, liver failure outcomes, transplant listing. It is useful mainly in the transplant. Child flu classification, cirrhosis prognosis, QSOFA, that is bedside sepsis screening. Scores also, though we are mainly dealing with the adult, but yes, sometimes the examiner slightly we little bit oriented towards pediatrics, so just remember of mortality. This is used in the PICU outcome prediction. Now, what are the application of this scoring system in ICU? Risk stratification for treatment intensity, resource allocation and triage, clinical research and trials where you want to mix the patient population, benchmarking ICU performance. The limitation, yes, population versus individual prediction. You cannot always predict that if your patient is having Apache 30, that every any patient with Apache 30 will finally die. You cannot say. Maybe outdated with new therapies. It's like whatever has started in 2000 with some of the scoring system that would be standing true in today's practice also, when we have so many newer innovations every day coming. And the performance varies across ICUs. It's not like only based on the scoring system you can label that every ICU would be having the same result, and it is not substitute for the clinical judgment. Always add machine learning and AI based model in any type of this type of question. Now, what are the application of this scoring system in ICU? Risk stratification, Dynamic real-time risk prediction is important. It's not that you do the scoring system in first 24 to 40 days or 15 days ICU stay. Biomarkers and genomics would be playing a bigger role in future when we want to add on or have these things also incorporated into the scoring system. And personalized ICU outcome prediction is something which is need of the hour. Now take home message: yes, the severity, organ dysfunction, everything would be better analyzed or guided by this clinical judgment. Now the next question is scoring system in liver disease. That also was asked, and the question was describe any one of these scoring system that is used in the liver disease. They were not CTP score, that is child torque puke score, but yes, MELD score is also one of the important thing because that is better in terms of CTP when it comes to the transplant, liver transplant listing. Now, multiple scoring systems assess severity of or the prognosis, like child torque puke, MELD or MELD sodium, CLIP SOFA, that is in ACLF, Apache 2 in ICU patients. We will describe CTP score in detail. Now, developed in 1964 by Child and Turcott and modified by the Pugh in 1973. Originally, they were trying to assess the operative risk in portal hypertension in surgery, but and liver transplantation. The parameters we all know: 5 parameters: bilirubin, albumin, PT or INR, ascites, and encephalopathy. And these are the scoring tables: 1 point, 2 point, 3 point. You can know, you can just go through, remember the lab values at which you will be labeling this as 1 point, 2 point, and 3 point. Ascites, encephalopathy. The classification again: class A 5 to 6 point, class B 7 to 9 point, and class C 10 to 15 point. That is decompensated form. Prognostic value: 1 year survival, class A is 100%, class B 80%, class C 45%. Transplant consideration: usually CTP if it is more than equal to 7. Now clinical application: risk stratification in cirrhosis, prognostic tool for survival, guide for liver transplant listing, surgical risk assessment. You must have seen any patient who are going for any surgery with cirrhosis of liver, they normally put this CTP score like as one of the guide of explaining prognostication. Coming to the limitation, this is a very subjective parameter having ascites and encephalopathy. Encephalopathy. For me, maybe encephalopathy 3, for you, maybe it is 4. Maybe for ascites, I would label it as severe ascites, you will label it as mild ascites, because the clinical judgment is very important. The ultrasound has to be, again, it is a subjective matter. Ceiling effect, you cannot label 10 to 15 is in the grade C. So 10 to 15 is a long, you can say 10 to 15. But if it is no, it is not a continuous like the MELD score. MELD score, the lab values have to be calculated, and it would give you a real number. But here A, B, C. So you cannot know whether my B patient will be for every patient who will be in the B category in my ICU in CLD patient, that will be having the same outcome. It will not be having a very clear, robust idea, and it is less accurate for short-term mortality prediction. Now, comparison with MELD, CTP is simple, bedside, it is an older system, but MELD is objective, continuous, superior for transplant allocation. Often they are used together in our practice. So take home message: CTP is simple and practical for bedside use, still relevant in clinical practice, but MELD is largely preferred for transplant allocation, but you can use both for the patient comprehensive assessment. Now, one more case, the question was asked here: mortality prediction score, rational and role of ICU, same as the ICU scoring system that I have explained, but the question was framed in a little bit different way. Mortality prediction score. Every score that is used in nowadays is having some or other mortality prediction. So we all know that ICU patients are heterogeneous, high mortality risk. Objective tools help guide the prognosis, benchmarking, and research. So mortality prediction is actually estimating probability of death in our ICU patient. The rationality behind this mortality prediction model is standardized assessment of disease severity that would be helping in clinical decision making. Benchmark ICU performance, I have already told this is one of the quality indicator nowadays being like used in our ICUs. Risk stratification in trials and research, and sometimes it is helpful in family communication. If you know that my patient is having this mortality prediction model coming in the last stage, so you can pretty well document it in your clinical notes also, and that would be helpful if there is some medical legal issues coming. Now, what are the characteristic of ideal score? I have already told you. Easy to calculate. It has to be reproducible. High discrimination has to be there. A good calibration has to be there. Universally applicable and updatable. Broad categories already I have told, but yes, you can always write about physiology based, organ dysfunction wise, diagnosis or condition specific, and composite models. Now, just one more thing I can give you as a classification. There we have told about disease specific, organ specific, something like physiologic basis. Now here what you can write, one is first day scoring system, repetitive scoring system. That is again one other way of dividing or classifying the scoring system. First day is Apache, SAPS and MPM. Repetitive SOFA, MODS and LOTS. These are some of the timelines of different scoring system from 1980 till 2006 and above. Already explained Apache, SAPS, SOFA, MPM. I'm just skipping because just for the sake of completion, because these questions have come. So you should not be feeling nervous when you are getting little bit slight different question than what each actually you have read. Some ongoing scores that have now in process. Apache 4 is right now in modified stage. There is a SAPS L. There are certain condition specific scoring system now so far for heart failure patients, and UK ICU database also they are having one score like ICNARC. Now strength of mortality scores already explained. These are benchmark, guides, triage and prognosis discussions. Limitations do not replace the clinical judgment, need recalibration. Role in ICU practice, again the examiner would definitely expect you should talk about research and clinical trials, administrative tools, so that you can use your resource, limited resource in some of the ICUs wisely, and quality has to be assured, and daily practice should be prognosis estimation, family communication, and some of the high mortality diseases you can use this as your helpful guide. Future direction, already told, machine learning, AI model, incorporation of biomarker, real-time EHR linked prediction system, and finally we should be reaching to the level of precision ICU care. Now 18th number question, ICU admission criteria. That was again one of the miscellaneous questions that was asked. Why we need admission criteria in ICU? Because ICU is a specialist unit for critically ill patients needing continuous monitoring and organ support. The purpose is early detection of deterioration, life-saving intervention have to be done, and multidisciplinary critical care. So the general principles of admission should be, when ward care is insufficient, you need to consider based on the severity of illness, reversibility of condition, need for invasive monitoring or advanced organ support. Ethical balance has to be there, benefit versus burden. You cannot always keep a patient who is 90 plus with moribund, with some of the end stage malignancy and the frailty and some of the things which cannot be reversed. So in that case, at least you should have a 25-year-old trauma patient who is in need of a bed, and you can allocate that resource to a patient where we can salvage some of the patients who are dying. Now these are this is from the 2023 December as per the Government of Ministry and Family Welfare. This is intensive care unit admission and discharge criteria. I have taken the screenshot from that exact guideline that was published. You must have seen this also. So there are certain ICU admission criteria I want to know, because this is from the Ministry of Family Health Welfare. So NB also in the examination or your NMC, they would be expecting that at least you should know about these 3, 3, 6 and 7 criteria. That this patient should be admitted in your ICU. This is as per the expert consensus statement published in 2023 December. Now you can always divide your ICU admission criteria based on certain, like, the localization, or the organ specific, or the emergency. So let's start with the airway indication. I'm not going into detail. I'm just giving you a brief structure template that you all know, but you can always write in this way. Clear? Impending airway compromise, need for elective or prophylactic intubation, failed non-invasive airway protection, the patient is in the ward where you are unable to provide NIV. So these patients are definitely shifted to the ICU. Respiratory indication, mechanical ventilation cannot be provided in the ward. Severe hypoxemia, PaO2, FiO2 less than 200, hypercapnic failure despite oxygen therapy or NIV, severe asthma, COPD exacerbation, not responding to ward measures, circulatory, again, hemodynamic instability requiring vasopressors or inotropes, persistent hypotension despite you have given some fluid in the emergency department or in the HDU or in the ward, post cardiac arrest care cannot be provided in the ward, unstable arrhythmias needing close monitoring. So these are some of the patients from the cardiac side. Neurologic indication, GCS less than equal to 8, where you need to protect the airway, status epilepticus requiring sedation, ventilation, rest ICP, rest, head injury, stroke, meningitis, encephalitis, acute neuromuscular weakness, where you are suspecting that this patient will be aspirating, or this patient will be retaining carbon dioxide, or this patient can stop breathing in case of GBS, where there is ascending paralysis. Renal indication, acute kidney injury when the patient needs dialysis in unstable patient, severe acidosis, severe electrolyte derangement, potassium is very high with ECG changes, severe hypo or hypernatremia, you cannot monitor the sodium in the ward, acute poisoning when the indication of RRT is there. Metabolic or endocrine indication, definitely decay patient with shock, altered sensorium, thyroid storm, myxedema, coma, severe lactic acidosis, tumor lysis syndrome. These are some of the very interesting and need of the hour indication where you need to shift the patient to the ICU. Sepsis and multi-organ dysfunction, again, severe sepsis, septic shock on, like, 2 or 3 vasopressors, MOD score more than equal to 2, organ support system, mechanical ventilation, vasopressors, RRT, advanced monitoring. You cannot do it in the world. Post-operative indication, high risk surgeries like cardiac, thoracic, neurosurgery, transplant. Major blood loss has happened in the OT. Patient has been, like, right now undergoing the massive transfusion protocol. So these patients cannot be managed in the ward. Post-op instability, you need to shift the patient to the ICU. Need for invasive hemodynamic monitoring. Trauma and burn, polytrauma with unstable vitals, head injury with low GCS, burn with more than 30% body surface area. Some ICUs they keep 40%, so it is variable, but at least you should know that burn patients with certain percentage of body surface area, you need to shift the patient to ICU. Airway involvement is there, though maybe the burn is not that severe, but airway involvement is there. Inhalational injury is there, so you need to shift the patient for the ICU. Massive transfusion protocol I have already told. As per the triage categories by Society of Critical Care Medicine, American Society, priority 1, priority 2, priority 3, priority 4. Priority 1 is a life-threatening condition needing active intervention, immediately shift to ICU. Priority 2, stable now, but yes, there is high chance of high risk of deterioration is there. Priority 3, critically ill with low chance of recovery, like advanced malignancy, poor prognosis. And priority 4, moribund patient, unlikely to benefit from ICU. So 3 and 4, you have to be a little bit like judicious in shifting this patient to the ICU. Discuss with the family. The goals of care have to be documented properly, and there should be a shared decision making. Contraindications of this, like ICU admission criteria, that you should be shifting any patient to the ICU. Terminal illness with no reversibility. Why to shift the patient to the ICU when you can, like, provide palliative care and family should be at the bedside. Patients with advanced directive or DNR orders. Futile cases where you are expecting that the patient is dying in 24 to 48 hours and everything has been documented well, the family understands. End stage dementia, advanced metastatic cancer, so it should not be like the shifting like the shifted to the ICU where the risk benefit is actually tilting towards the risk more. Coming to the summary part, ICU admission guided by severity, reversibility, prognosis, and ethical principle. Balance the resources versus benefit in one of the paramount importance. You cannot, like, subject any patient to ICU and where the needy patient is not getting a bed. Now the 19th number question, again very important from infection control practice purpose, care bundles in ICU. So that was asked in the examination. So I would be discussing under certain headings. Critically ill patients are at high risk of complications due to invasive devices, organ dysfunction, and prolonged ICU stay. So variability in practice often leads to the worse outcome. So we don't know that Mr. X will be doing the same thing like Mr. Y, and maybe X ICU would be maintaining the same type of dedication like the Y ICU. So that's why we need to have some care bundles. That is a systematic approach to unify evidence-based care across the teams. So if it is at the middle of the night also or middle of the day also, weekend also, weekdays also, it would be provided important. It cannot be 10, 12. It cannot be also like not too much or like too less or too much. So that when performed together and reliably, so everything has to be done together and reliably, that would be leading to the better outcome than when implemented individually. So you cannot like justify that my therapy or my intervention is working or not when you are doing only one or two. If you are doing all the bundle components together reliably, then only you can say whether your intervention is working or not. Emphasis would be to have a collective impact than the individual effect. Example, VAP prevention bundle versus single intervention. Like if you are only going for head of bed elevation, then you will not get a good result than if you are going with all the VAP prevention bundles. Now the rationale behind these bundles are: it improves safety, reduces complications, enhances patient outcomes, it standardizes the care delivery in complex ICU settings, reinforces teamwork and accountability, that you need to again and again reinforcing the bundle components, and it translates guidelines into daily bedside actions. So it's not only which is written in the guidelines, rather which is workable principle in your ICU. Now the key features: limited number of intervention, 3 to 5. It cannot be too high, too much, or too less. Each intervention is supported by high quality evidence. Everything has been studied well. You cannot add anything into the VAP or the CLAPSI bundle and say that yes, this is also a bundle component. No, it has to be supported by very good research. Literature is supporting that yes, if you are going with head of bed elevation, then definitely it has certain physiologic and pathophysiologic principles. It is easy to monitor and audit for quality improvement, something we can do regular auditing. So this has to be very simple one. It cannot be complicated. And all are non-compliance principle, like partial implementation is not equal to bundle compliance. Very clear. Now types of bundles in ICU, I hope everybody knows about it, but it can be divided again into prevention bundles, management bundles, procedural bundles, daily care bundles. Prevention bundle is aimed to reduce device related infections like VAP, CLAPSI, COUTI. Now management bundles, when you are trying to optimize some of the acute illness like sepsis, ARDS, AKI. Procedural bundle, when you are doing some procedure but you want to have it foolproof, no complication like central line tracheostomy or bronchoscopy. Now daily care bundle, routine checklist, best measure for ICU patient like first of BIDS, something like that. Now, I am just showing you some of the slides again. I am not expected to discuss VAP bundles also at this time. But yes, these are some of the things you should be having at the tip of your tongue, at least before going to the exam. I'm just showing you the slides. I'm not expected to explain the sepsis resuscitation bundle hour one. But in the examination, if you are getting a question, you are expected to write short notes or long notes exactly what is right now you are being seen, showing or shown, something like that. Within 6 to 12 hour, that is also again another bundle. ARDS ventilation bundle, daily ICU care bundle, first of BIDS. Then what are the impact of bundles? Evidence shows that significant reduction in the VAP, CLAPSI or COUTI rate is there. Mortality in sepsis and ARDS has also reduced and improves compliances with the best practices, strengthen multidisciplinary teamwork, culture of safety, and forms the backbone of ICU quality improvement programs. At the take home message, care bundles are small, evidence based, practical steps applied consistently. It requires full compliance for maximum benefit, widely applied in ICU for infection prevention, sepsis, ARDS, and daily care. Bundles transform guidelines into bedside actions, saving lives daily. Now, I think the last question between we are finishing and you are here today. So you want all of them, this or not? The last question, biomarkers in critical care. How many of you are with me? Yes. I know everybody will be saying because this is the last question. Why to take the blame that yes, sir, we have not given one thumbs up and you have stopped the class because of our little bit laziness. Okay. I know you will be giving three, four thumbs up together. Okay. So the question related to biomarkers in critical care can be asked in a different way. It will not be straightforward biomarkers in critical care. Rather, it can be asked in a clinical wise also. Like a 55-year male with septic shock, rising lactate, and procalcitonin. How would biomarkers guide your management? This can be also a clinical question, which would be just you can say the replacing the straightforward question. Now the headings: introduction, what is a biomarker, ideal characteristic of ICU biomarker, different biomarkers, how to apply smartly clinically, limitations, take home. Now, if you will be just going with the introduction, what is a biomarker? I have already told in like the question before when I was explaining about AKI. Biomarker is a measurable indicator of a normal biologic process, pathogenic process, or response to therapy. Remember what I am actually trying to highlight here. It is actually something indicating the biologic process, pathogenic process, and also if you are giving some therapy, how your body or your patient is actually responding. That also you need to see through a biomarker. In critical care, laboratory or imaging based measurable parameter that guides diagnosis, prognosis, monitoring, and therapeutic decision. So a lot of things you need to know or that would be helpful. Diagnosis, prognosis, monitoring, or therapeutic decision. Why important in ICU? ICU patients are complex, unstable, and time sensitive. Biomarkers provide objective, rapid, reproducible data beyond clinical science and that help in early diagnosis, risk stratification, therapeutic guidance, monitoring response, and outcome prediction. So this is something which will be definitely helpful to you. Now, if we'll be just going with characteristic of ideal biomarker, you can see here high intensity, high sensitivity, increased myocardial concentration after heart attack. There should be rapid release to allow the early diagnosis, long half-life to allow the late diagnosis as well. Then high specificity. Its absence in tissues other than myocardial 1. Its absence in healthy patient because legend is how it exclude that exclude that MI or something like that. Assay related characteristic, good cost effective ratio, easy to assay, short processing time. It is not like it will be taking 9 days, 7 days, 5 days to just get the report. And high precision, and this should be also helpful in like guiding the therapy and predicting the prognosis. Already discussed, rapid turnaround correlates with disease severity and outcome, guides therapy decision, cost effective, reproducible, and validated. Now, some of the biomarkers as per the disease itself: infection and sepsis biomarker, CRP, procalcitonin, IL-6, everything you need. What is the utility? Both in CRP, procalcitonin, strength, clinical use. Is there any landmark trial that have used this biomarker and how you are actually utilizing or using this in the bedside care? IL-6 and TNF alpha like elevated in cytokine storm, severe sepsis, COVID-19, CAR T therapy also IL-6 and TNF alpha is used as a biomarker. And this is useful as a adjunctive marker for the prognosis, severity stratification, and to identify patients for the extracorporeal cytokine removal therapy. Now, the again infection sepsis biomarker 2, presepsin, proadrenomedullin, And you can see here, this is soluble CD14 subtype released by monocytes in response to bacterial infection. It rises early in sepsis before the other, like the parameters and the biomarkers start rising. It correlates with ICU severity score and mortality. It is used as a prognostic marker. Proadrenomedulin is a stable fragment of adrenomedulin, a vasodilatory peptide involved in endothelial function. It is elevated in septic shock and severe infection. It is a strong predictor of organ dysfunction, vasopressor need, and mortality. Clinical utility that will be helpful in early recognition of sepsis, help in risk stratification and prognostication. And again, if you complement it with the CRP and procalcitonin, maybe a better antibiotic stewardship program and mortality prediction can be there in our ICU care. Now coming to the cardiac biomarkers, again, troponin, high sensitive troponin T, troponin I, BNP, NT-proBNP, these are some of the biomarkers along with ST2, galectin 3, these are novel heart failure risk markers which are emerging. Now kidney marker, I have already told, not going into detail. Liver injury, conventional is bilirubin, ALT, AST, INR, but they are late indicator. Now they are going into like having some newer biomarkers like microRNA 122, keratin 18 fragments, ammonia. Now neurologic, neuron specific enolase, S100B protein, GFAP, which is glial fibrillary acidic protein, and the role also we can prognosticate in hypoxic ischemic encephalopathy. So this is the upcoming biomarker that can help in the prognostication and also the therapeutic decisions. Now, so respiratory ARDS biomarker, this can be asked as a short note also because this is helpful in having the phenotypes and endotypes also. SPD, which is surfactant protein D, these are marker of alveolar epithelial injury elevated in ARDS and correlated with severity. They may help to distinguish ARDS from cardiogenic pulmonary edema. The next one is soluble receptor for the advanced glycation end products. They are released from the damaged alveolar epithelial cells, reflects epithelial barrier dysfunction in ARDS. Higher levels, if you are getting, that would be linked with the worse outcomes and ventilator induced lung injury. Proadrenomedulin, I have already told, this is again one like just like sepsis, systemic marker of endothelial dysfunction, elevated in sepsis related lung injury, strong prognostic value in for the mortality and progression of ARDS, clinical relevance, currently research use but not routine, and useful in phenotypic ARDS, like hyperinflammatory versus hypoinflammatory subgroups. And they may guide precision medicine, which is in upcoming in our future trials. Hematology and coagulation biomarkers, D dimer, thrombin, antithrombin coagulation, thromboelastography, like TAG and ROTEM, where you can get the global coagulation assessment, whether you want to give FFP, cryo, platelet, or do nothing. So that also you can give through the take. Metabolic or stress biomarker, serum lactate, cortisol, ACTH stimulation test, mid-regional proadrenomedulin. These are something which are upcoming. On emerging omics based biomarker like circulating cell-free DNA, exosomes, microRNA. These are early detection of organ failure, proteomics, metabolomics, transcriptomics. All these omics towards the personalized ICU care. And then everything, all these biomarkers can be combined with AI based biomarker panel for the precision medicine. Now what are the limitation of the biomarkers? They are costly. We do not have this in every center. Assay variability between labs to labs, we don't know that this lab has this cutoff, that lab has different cutoff. Influence of different comorbidity, it is not straightforward. The heart failure patient may be having some kidney problem, liver problem, so the biomarkers can talk between these organs also, and it should not it should complement, not replace the clinical assessment. Now the take home message that no single biomarker is perfect. Panels plus serial trends are the best strategy, and the biomarkers are useful for early diagnosis, prognostication, and therapy antibiotics. So I know I have tried, we have tried, and we want to have the time on the result day when we will be glad to inform you if we get the result before you are getting the result, that you passed all, and congratulations to all of you. And I hope that day all of our efforts for last 2 weeks, Friday, Saturday, Sunday, Friday, Saturday, Sunday, that will be fruitful. And maybe you will be running after finishing your final exam. If you go through all these videos in the next upcoming 25 days, you will be running after writing the 3R, 3R, 3R paper for continuously 3 days, and you will be throwing, don't throw the papers, otherwise your answers will not be calculated. Thank you very much for your patient listening. I've just crossed 3 hours non-stop, and I hope you have been benefited to a great extent after 6 days of extensive discussion. Neuro part is pending, so Dr. Sanant would be recording this and sharing with you maybe in couple of days. Thank you very much. If you have anything you want to share with us, please post in this group, post in the WhatsApp group also. We will be helping you out. It's not the end. Maybe our faculties would be with us in the group also. They would be guiding you. If you have any problem, you have anything you want to get from us as a note, or like some like articles, short notes, somebody would be definitely helping you. Our whole effort will be complete if you successfully complete your exam, at least the first part, like that you will be appearing the exam. And definitely in the practical also, I would be assuring you, we are coming up with on-site practical course also, and also again similar to this real type simulated table vivas and clinical cases. Keep like stay tuned with all of us, and wish you all the best. Thank you very much.